Podcasting from beautiful Sydney, the city of Opera House, Darling Harbour, Blue Mountains, and beautiful beaches. This is ICU Primary Prepcast, a monthly podcast about physiology and pharmacology in intensive care.
Hi, I'm Maddi.
Hi, I'm Swapnil. And today it's our first episode in 2020. So wish you Happy New Year, Maddi, and to all listeners.
Thank you, you too.
And how was your New Year celebrations, Maddi?
Well, I was working a night shift, so pretty fun. How was yours?
Sad story of ICU registrar's life.
Yeah, that's right.
I hope this year will bring your dreams true, and those who are sitting for ICU primary exams will clear this primary exam in first attempt. So wish you all the best for 2020. And this is our first episode, and we are going to dive deeper into cardiovascular physiology. And this is our episode number 4 for cardiovascular physiology. So let me start by asking you, Maddi, can you please outline the important features of left ventricular pressure volume loop?
Sure. So the left ventricular pressure volume loop plots the left ventricular volume in milliliters against the x-axis and the left ventricular pressure in millimeters of mercury on the y-axis, and does this over the whole cardiac cycle. The left ventricular pressure volume loop can be divided into 4 basic stages: ventricular filling, isovolumetric contraction, ventricular ejection, and isovolumetric relaxation. If we start at the beginning of ventricular filling, when the mitral valve opens and the end systolic volume of the LV is about 50 mils, we can call this point A. The ventricles fill and the LV pressure slowly rises to a point where the LV pressure rises above the left atrial pressure and the mitral valve closes. This can be termed point B, which represents the end diastolic pressure and end diastolic volume, and is usually around 130 milliliters. The line from point A to point B is phase 1 and represents ventricular filling, and the horizontal distance between these 2 points is stroke volume. Phase 2 then begins, which is isovolumetric contraction, where the volume in the ventricle remains the same as all valves are closed, but the pressure rises rapidly. This continues until the intraventricular pressure exceeds the aortic diastolic pressure, often at about 80 millimeters of mercury, and the aortic valve opens, and this is point C. Phase 3 then begins, which is the period of ventricular ejection. During phase 3, the systolic pressure rises to about 120 millimeters of mercury, and ventricular volume decreases as blood is ejected from the ventricle. There is a fall of pressure to about 100 millimeters of mercury at the end of systole, to point D, and when the LV pressure drops below that of the aorta and the aortic valve closes, this is point D. This point marks end systolic volume. Phase 4 is isovolumetric relaxation, where both the aortic and mitral valve closes, so there is no change in volume, but the ventricular pressure returns back to its diastolic level. When the intraventricular pressure falls below the atrial pressure, the mitral valve opens and point A starts, and the whole cycle begins again.
That's great. And I will include the diagrams of LV pressure volume loop in the show notes. So what is the other important information that you can obtain by looking at LV pressure volume loop apart from what you said?
So there are several other important characteristics of the LV pressure volume loop that can be obtained. The first thing, the LV end diastolic volume, or point B on the loop, is an indicator of preload. Increased preload will shift the whole curve to the right, but end diastolic volume will increase more than end systolic volume, so that stroke volume, or the point between point A and point B, is increased. Afterload can also be illustrated by the slope of the line connecting the end diastolic volume, or point B, with the end systolic volume, or point D. Increased afterload will increase the slope of this line, as end diastolic volume or pressure, such as point B, will not change, but end systolic pressure and volume will increase. Therefore, there will also be a reduction in stroke volume. Contractility can be represented by the slope of the end systolic pressure volume line. That is the angle of the line between the end systolic point, or point D, and the x-axis. With increased contractility, the end systolic pressure volume point is moved to the left and slightly upwards, thus increasing the gradient of the end systolic pressure volume line. Finally, the slope of the line from point A, or when the mitral valve opens, and point B, or end diastolic volume, gives the elastance of the ventricle, and this line is known as the end diastolic pressure volume relationship. Increased elastance, such as in diastolic dysfunction, will increase the slope of this line. That is, ventricular pressure will be higher for any given ventricular volume. Finally, the area within the pressure volume loop represents stroke work of the heart.
Great. So one of the common scenario in ICU and one of the kind of common reason for ICU admission, that patient coming with circulatory shock. Now, this term itself has interesting history, and I still don't understand why we use the term shock. But can you define shock, and can you classify different types of shock?
Sure. So shock is a broad term for a clinical condition characterized by the failure to deliver and or utilize adequate amounts of oxygen to supply the needs of the body. It can be classified according to the major component of the circulation that is affected into hypovolemic, cardiogenic, obstructive, and distributive shock. So hypovolemic shock is inadequate preload. Cardiogenic shock is a pump failure or failure of the heart. Obstructive shock is obstruction to the pump or the heart outflow. And distributive shock is altered vascular capacitance. Shock can also be classified physiologically into hypoxic, anemic, stagnant, or histotoxic shock. So hypoxic is inadequate oxygenation within the lungs. Anemic is adequate oxygenation but inadequate oxygen carriage within the blood. Stagnant is adequate oxygenation but inadequate blood flow to the body. And histotoxic is adequate oxygenation but the tissues themselves are unable to utilize the supplied oxygen. Both classification systems are overly simplistic, and shock may be caused by multiple categories within these groups.
Great. And I was just doing some search on the word shock, how it came into existence. And it's quite an interesting story. So basically, it's originated from French word CHOC, which was described first in a trauma victim in 1740 by Henry Francois Ledran. And he described CHOC, shock, as a reaction to the sudden impact of missile. And since then, it got translated into English as a shock, and in 1795 by James Latta. And since then, we are using this term for all the circulatory shock, which is quite interesting. So let's consider a scenario where we have a patient who came after trauma, had sustained acute loss of 1 liter of blood. What are the different cardiovascular changes will occur in this patient?
So firstly, it's important to note that 1 litre of blood loss is a significant amount, and it's about 20% of total blood volume in an average 70 kilogram person. So this will result immediately in a decrease in venous return and thus a decrease in cardiac output via the Frank-Starling mechanism. The body's subsequent cardiovascular changes occur with an aim to reduce further blood loss and to ensure adequate blood flow to vital organs. So the following cardiovascular changes occur. There is a decreased systolic blood pressure, but a smaller decrease or even a slight increase in diastolic blood pressure, resulting in a narrow pulse pressure. The mean arterial blood pressure is usually decreased. The body is interestingly able to maintain a normal arterial pressure for longer than it is able to maintain a normal cardiac output. Initially, there will be no change in hemoglobin or hematocrit as whole blood is lost. There is activation of the baroreflex. The decrease in arterial pressure reduces the firing rate of the baroreceptors. This results in a decrease in vagal tone and an increase in sympathetic tone, resulting in increased heart rate and contractility. Within the vasculature, increased sympathetic stimulation causes arteriolar constriction, which increases systemic vascular resistance, and venoconstriction, which helps to increase venous return. This baroreceptor response can compensate for a 10 to 15% loss of total blood volume without significantly affecting cardiac output. Blood flow is also redistributed from less important organs, to the more important organs such as the brain and the heart in order to preserve sufficient oxygen supply. Both the cerebral and the coronary circulations have good local blood flow autoregulation, thus helping them to maintain adequate perfusion. The decreased perfusion to other non-vital organs can lead to acidosis, which activates the chemoreceptors, thus also resulting in increased sympathetic activity. At about 15 to 20% blood loss, the Barcroft-Edholm or the depressor reflex is activated. The blood loss causes decreased right atrial pressure, and at a certain right atrial pressure drop, the depressor reflex is activated by mechanoreceptors within the atrium, which then overrides the baroreceptor reflex. This depressor reflex results in increased vagal tone, which reduces heart rate and decreases cardiac output, thus hopefully promoting hemostasis by slowing circulation, which reduces bleeding and promoting clot formation. This reflex is often suppressed in acute blood loss due to increased sympathetic activity from the injury itself and the subsequent pain and fear that's activated. There's also increased sympathetic activation, which stimulates the release of catecholamines from the adrenal gland, which further increases sympathetic activity and also increases the release of cortisol. The sympathetic activity also stimulates renin release, which results in increased levels of angiotensin II and aldosterone, which results in vasoconstriction, renal afferent and arteriolar vasoconstriction, antidiuretic hormone release, and increased renal reabsorption of sodium and water. Cardiopulmonary baroreceptors are activated, which also cause the secretion of antidiuretic hormone from the posterior pituitary. This results in vasoconstriction via the V1 receptors and retention of water in the kidneys via the V2 receptors. There is a decrease in capillary hydrostatic pressure due to increased sympathetic activation, causing arteriolar vasoconstriction, whereas the oncotic pressure remains the same. This new imbalance between the Starling forces causes a transcellular shift of fluid from the interstitial to the intravascular space, which works to restore volume within the intravascular space. This, combined with the renal retention of sodium and water, results in hemodilution and a drop in hemoglobin and hematocrit. There is also an increased release of erythropoietin within 24 hours of hemorrhage.
Great. So even 1 liter blood loss seems pretty common scenario, and we replace with massive transfusion, but a lot of physiological changes are happening underneath. So it's quite important to understand what happens when somebody loses that much of blood. Now, let's move on to the another scenario, which is also kind of not uncommon in ICU. That is, patient presented with pneumonia, he's hypoxic, and in order to improve the oxygenation, the night registrar has increased the PEEP to 16 centimeter of water. What are the cardiovascular consequences of positive end expiratory pressure, or PEEP?
So positive end expiratory pressure is the application of positive pressure to expiration so that airway pressure is artificially kept above atmospheric pressure. The cardiovascular consequences of PEEP differ depending on the cardiac function and the fluid status of the patient. But we can think of the effects in terms of the effect on preload, afterload, myocardial oxygen consumption, and cardiac output. Firstly, starting with preload, increased PEEP results in increased intrathoracic pressure. Venous return is determined by the gradient between mean systemic venous pressure and the right atrial pressure, and the right atrial pressure is increased with increased PEEP, which results in a decrease in venous return and thus a decrease in preload. However, this effect is also often minimized by the compensatory increase in sympathetic tone and an increase in intra-abdominal pressure, which increases mean systemic venous pressure. However, in hypovolemic patients, this increase in intra-abdominal pressure can cause collapse of intra-abdominal veins, thus decreasing preload further and decreasing cardiac output. Conversely, in patients with acute congestive cardiac failure, the decreased preload may place them back on a more efficient part of the Frank-Starling curve, thus increasing cardiac output. In terms of the effects on afterload, we can think of the effects on the RV and the LV afterload. In terms of the RV, Increased intrathoracic pressure increases pulmonary artery pressure and pulmonary vascular resistance, therefore increasing right ventricular afterload. This increases right ventricular work and oxygen demand and may worsen RV dysfunction. However, the PEEP may improve lung volumes and reverse local hypoxia, resulting in vasodilatation of previously constricted vessels. This may then actually decrease pulmonary vascular resistance and thus decrease RV afterload. Coming to the left ventricle afterload, increased intrathoracic pressure will decrease LV transmural pressure, which decreases LV afterload. This reduction in afterload can be especially beneficial in acute congestive cardiac failure by reducing myocardial oxygen demand, improving cardiac output, and reducing pulmonary edema. In terms of myocardial oxygen consumption, PEEP will generally decrease the myocardial oxygen consumption. And finally, in terms of cardiac output, the effect of PEEP on cardiac output generally depends on whether the patient is more preload or afterload dependent. Healthy patients without cardiovascular disease are generally more preload dependent, and PEEP will either cause no significant change to cardiac output or will decrease cardiac output if they are hypovolemic. In patients with RV failure, PEEP may decrease cardiac output by decreasing preload and increasing RV afterload. And in patients with LV failure, they are generally more afterload dependent, and PEEP may therefore increase cardiac output by decreasing LV afterload.
Thanks, Maddi. And I think this is really important to understand, especially when you are applying the PEEP in patients with ARDS. If you exceed the certain limit, it might cause the state which we call as acute cor pulmonale. And this is a term coined by Anton Willebaron. And I think it's really important. That's why to monitor RV when you're either doing the recruitment maneuver or when you're applying the excess PEEP in patients with ARDS to make sure that RV is not failing. Otherwise, the things will get worse. Now, can you please outline the physiological responses to chronic anemia?
Anemia is a condition in which the number of or oxygen carrying capacity of red blood cells is insufficient to meet physiological needs. Oxygen carrying capacity is determined by the hemoglobin concentration multiplied by the saturation of hemoglobin multiplied by the oxygen binding capacity of hemoglobin plus the amount of dissolved oxygen in the blood. Therefore, a significant decrease in hemoglobin will significantly affect the oxygen carrying capacity of blood. As oxygen delivery is dependent on oxygen carrying capacity multiplied by the cardiac output, in order to maintain oxygen delivery in significant anemia, cardiac output must increase. There are several responses that occur with chronic anemia, mainly to increase this cardiac output. So there's decreased peripheral vascular resistance due to decreased blood viscosity and decreased oxygen delivery, which causes local vasodilatation. There is an increased cardiac output due to a decrease in the total peripheral resistance, which decreases in afterload, and an increase in preload due to decreased blood viscosity. This increased cardiac output helps to offset the reduced oxygen carrying capacity of the blood. The body also redistributes blood flow to vital organs such as the brain and the heart, and there is an increased oxygen extraction, with the oxygen extraction ratio increasing in the body and therefore a decrease in mixed venous oxygen saturation. The coronary and the cerebral circulations already have a high oxygen extraction ratio and are unable to increase oxygen delivery via this mechanism, but the increased oxygen extraction ratio does occur in the kidneys, skeletal muscle, and skin. Chronic anemia also causes an increase in 2,3-DPG, which causes a right shift of the hemoglobin oxygen dissociation curve, and there is a stimulation of erythropoietin and angiogenesis.
Great. So far we discussed some of the cardiovascular changes in some of the pathological conditions. Now, let's talk about cardiovascular changes in some of the abnormal spectrum of healthy individuals, say, for example, elderly patients. So can you please list the changes to cardiovascular physiology in healthy elderly patient?
So the changes in cardiovascular physiology in a healthy elderly person can be thought of in terms of myocardial changes and vasculature changes. In terms of myocardial changes, we'll start with the structure of the myocardium itself. So there is concentric ventricular hypertrophy, which causes an increase in cardiac size. And there's a hypertrophy of the myocytes themselves, but an actual decrease in the myocyte number. There is also an increase in the atrial size and a change in the overall shape of the heart from elliptical to spheroid, with an asymmetrical increase in the intraventricular septum more than the free wall. There's also an increase in valvular circumference predisposing to valvular heart disease. In terms of the systolic and diastolic function, a resting systolic function does not change in the healthy elderly patient, but there is a significant change in diastolic function, with a decrease in diastolic compliance and ventricular filling, especially in the early or the passive diastolic phase. As ventricular filling is then more reliant on later or active filling, it becomes more reliant on atrial contraction for filling. There is also an increase in isovolumetric relaxation time. In terms of cardiac output, there's a decrease in cardiac output and an increase in left ventricular afterload. There is also fat accumulation around the sinoatrial node and a decrease in number of pacemaker cells. In terms of the ECG, you might see an increase in PR interval, a leftward QRS shift, and a blunted respiratory sinus arrhythmia. Now, in terms of the autonomic or integrated response within the heart, there is a decrease in the autonomic receptor number and density, and therefore a decreased sensitivity to catecholamine. There is a decrease in maximum heart rate, a decrease in maximum ejection fraction during exercise, and an impaired baroreceptor reflex. Coming to the vasculature, elderly people have thickening of the intima and media vasculature, resulting in reduced distensibility, increased total peripheral resistance, and increased pulse pressure and mean arterial pressure. There is some endothelial dysfunction with decreased nitric oxide release, and there's also an increased diameter of the aortic root itself.
Okay. And the second category is the morbid obesity. So can you please outline the cardiovascular changes associated with morbid obesity?
Morbid obesity is defined as a body mass index of over 40 or a BMI of over 35 and experiencing obesity-related health problems. The cardiovascular effects of obesity are interrelated and complex, but can be subdivided into cardiac, vascular, and hormonal changes. Starting with the cardiac changes, left ventricular hypertrophy occurs secondary to increased afterload due to hypertension and/or volume overload. There is also right ventricular hypertrophy secondary to LV diastolic failure and/or increased pulmonary vascular resistance from chronic hypoxia, such as in the cases of OSA. There is fatty infiltration of the myocardium and the cardiac conduction system, which increases the risk of arrhythmias. This risk is also increased due to the increased incidence of hypoxia, hypercapnia, coronary artery disease, increased circulating catecholamines, and OSA in the obese population. There is also impaired left ventricular systolic function, especially during exercise, with a slower and a smaller rise in ejection fraction. There is diastolic dysfunction secondary to myocardial fibrosis, which impairs relaxation, and LV dilatation, which increases wall stress and reduces compliance. Obese individuals have increased stroke volume, cardiac output, and left ventricular and diastolic pressure, but the heart rate usually remains unchanged. In terms of vascular changes, there is increased total blood volume due to increased angiotensin II and aldosterone. Splanchnic blood flow is increased, but renal and cerebral blood flow remains the same. There is increased basal oxygen consumption due to increased size, and there's endothelial dysfunction due to hormonal factors which increase the risk of atherosclerotic disease. There is also increased blood pressure. In terms of hormonal changes, there's increased leptin, which is secreted by fat stores and contributes to left ventricular hypertrophy. There's increased angiotensinogen, which increases angiotensin 2 and aldosterone and results in hypertension, sodium and water retention, and LV hypertrophy. There is increased plasminogen activator inhibitor 1, which reduces fibrinolysis and therefore increases the risk of thromboembolic disease. And increased catecholamines, which increase contractility and systemic vascular resistance. Increased inflammatory adipokines impair endothelial function, and there is increased systemic vascular resistance.
Thanks, Maddi. So that's the end of the easy part of the podcast. But before we move on to the difficult part, Maddi, what are your resolutions for the new year?
I try not to make resolutions. I find them easy to break. But hopefully try and get my fellowship exam done.
Okay, that's good. So all the best. But I was hoping to hear that you're not going to ask me the question as one of the resolution.
No, it's the best part.
I was actually about to make the resolution that I'm not going to answer your questions. But I guess listeners like this part. So yeah, we'll continue our tradition. So
Okay. So why does the cardiovascular system feel out of place in biology class?
Maddi, I didn't ask you to increase the difficulty level of questions. Oh my goodness. Cardiovascular system feel out of place in biology class? No idea, Maddi. Sorry.
It's a heart, not a science.
That was interesting intellectual joke. Thanks, Maddi. That's the end of our podcast on cardiovascular physiology part 4. We will be back with another episode in months' time. Till then, goodbye.
Thanks for listening. See you next time.